All right, thanks so much, and I'm so excited to present to you all today. Now, I will say I'm already, since I'm technically not very proficient, I've got two laptops here, and I'm going to be advancing them because one of them's got the talk on it, one of them's got some of my notes on it. But so real quick, I'm Matt O'Brien. I'm a psychologist and behavior analyst. I am an assistant professor of pediatrics at the University of Iowa Hospitals and Clinics, where I direct our severe and challenging behavior programs. I do clinical work and research in severe and challenging behavior. I've been doing work with individuals with severe and challenging behavior for about 16 years now, and have been the director of services for about 10. So I am going to talk about managing challenging behavior at home, but I do want you to know that this talk can go any route. I am happy to stop at any point and answer questions. I'm happy to entertain any kind of comments or questions at any point. So please just raise your hand, yell it out, throw something at me, make it soft. I am willing to stop at any point just to chat. So, all right. So briefly, here are the learning objectives. We're going to talk about function-based model for understanding problem behavior. Hopefully you'll learn some behavior management strategies along the way to address challenging behavior, oftentimes using adaptive behavior to replace it. And then, I can put these on the middle table maybe. And then also, hopefully you'll gain some knowledge of the resources available in the state of Iowa to address or to help support you with challenging behavior in the home or in the school if you're a school person. All right, so I want to start off by distinguishing between challenging behavior and aberrant behavior, two very different things. Challenging behavior requires treatment. It's something that we have to intervene with. Aberrant behavior may not require treatment. And so this cartoon does a good job of depicting an aberrant behavior that obviously does not require treatment. So in this comic, you have a family sitting down to watch television, and the son gets up and says, "Oh, TV's boring, I want to go read." And the mom's aghast and says, "Where did we go wrong?" Okay, aberrant behavior for sure for this family. Not something we probably need to treat, right? The kind of stuff that I'm talking about is physical and verbal aggression, self-injurious behavior, destruction, elopement, severe refusal behavior. Those are the kind of things that we're going to address today. All right. So something that I want you all to take away from this talk is that behavior is learned. And the teacher of behavior is the environment, okay? So keep that in mind as we go through this. We are going to talk about something called the Operant learning model, which is the way that the basis for understanding both why behavior occurs and how it occurs. So how does it learned? And it all starts with a behavior. So the cool thing about this model is that it doesn't just explain problem behavior, it explains all behavior. So it could explain why I came in today and saw a friend and said, "Hi, Patty." It also could explain why a child yesterday in clinic came up and bit me in the shoulder. It can explain both of those, and we're going to talk about that. And I think maybe what we could do is maybe ask for an example of a behavior to start with, so that maybe we can carry that forward throughout the rest of these slides. Does anybody have an example of a behavior that you engaged with today? Could be anything. Make it up if you have to. What's something you did this morning?
Severe refusals.
Okay, severe refusals. What about you, though? Tell me something you did today.
Oh, what I did?
Yeah. Could be anything.
Small breakfast.
You had breakfast.
I'm not hungry this morning.
Oh, you skipped breakfast.
Yes.
Okay. Well, that's a little bit. That's the absence of a behavior, but we can still work with that. We'll keep that in mind. Thank you. And what's your name?
James.
James. All right. James skipped breakfast. We will get into that. All right. So behavior is not random. One thing that you should be aware of is that there are internal and external signals that exert some control over our behavior. So there are things in our environment, both things you see, but also things internally that might trigger or evoke our behavior. We call these things antecedents. And these are the things that occur before behavior occurs. So let's take your example of not eating breakfast. What was going on before you decided not to eat breakfast?
I woke up real early.
You woke up real early. And then do you usually eat breakfast?
Yeah.
Okay. So what was different today?
Well, I'm looking forward to the conference, so I was kind of nervous, I think.
Okay, so you had some internal signals, something that made you a little bit nervous, a little bit anxious maybe, and so maybe evoked this, "I'm not going to eat today." Okay. So antecedents are what evoke or bring on a behavior. However, it's what happens after the behavior. It's the consequences that determine whether or not that behavior is more or less likely to occur in the future. So consequences can be rewarding or beneficial, and in that case, they're likely to reinforce the behavior, make it more likely to occur again in the future. They can be absence of any rewards. So I engage in a behavior and nothing really happened. But they can also be aversive, or what we call punishing. So had you eaten breakfast and it made your stomach upset because you were nervous, it might have been punishing to that behavior, okay? So there's this circuit that occurs, this reward circuit, and like I said, when a rewarding or beneficial outcome follows a behavior, that circuit is strengthened. When an aversive or a negative outcome occurs, it weakens that circuit. And so you can think about it, sometimes strengthened, sometimes weakened. There's a lot of research into this that I don't want to get into. But basically think about any behavior that we want to stop, we have to weaken that circuit. Any behavior we want to increase, we have to strengthen that circuit. Okay. What was the concept? Let's just carry this through with your example. So you didn't eat breakfast. How did that go?
I'm hungry now.
You're hungry now. So it may have had a bit of a punishing effect. Had you eaten breakfast and your stomach felt good, you felt full, and you're not hungry now, that might have had a reinforcing effect. That's why we eat, right? We eat because it makes us feel better. It makes us feel full. There's other influences on our behavior too, though. And one group of influences that we talk about is something called setting events. These are more distal is what we call them, meaning that they're not right there occurring at the time. These are things like hunger, pain, medications, sleepiness, mental health, like we can feel down or depressed some days. You gave a perfect example of a setting event. You were a little bit anxious. That's an internal signal that maybe it wasn't, in your case, it actually was more directly related to your behavior, but let's just pretend like you ate breakfast today, but you're anxious beforehand. It may have increased or decreased the likelihood of you eating breakfast. My point is these things influence our behavior, but they're usually not the cause of our behavior, but we have to keep that in mind. All right, so behavior develops through learning. However, the reason behavior continues to occur is because it's meaningful. And it's communicative. Behavior is communication. This cartoon gives an example of this. And in this cartoon, Lucy says to Linus, she says, let's see, how can I put this into words? What I mean is, what I want to say is, how can I put into words what I'm trying to say is, and pow, she punches him right in the face. And he says, rats, I was hoping she could put it into words. That's behavior. She's communicating something. Now, he doesn't really know what she's communicating. And a lot of times we can tell what someone's communicating. But in this case, she's using problem behavior to communicate. All right, so what's your child's problem behavior saying? There are many things that problem behavior can be communicating. I'm going to focus on two of the more common ones. Probably the most common one is the message that your child is saying, I want something, and usually I want it now. And what are we talking about? We're talking about, hey, you took away the iPad and now the child is upset because you took that away. Or you said no to a preferred snack or food. Or maybe the sibling is busy and not attending to your child, and so the child engages in disruptive behavior to get their attention.
What's the stick with taking the iPad away?
Yes. That as a colleague of mine says, the iPad is like crack for kids. And I agree. Then we also have this message of, I don't want to do this. And that message is, I don't want to do chores. I don't want to do the schoolwork. I don't want to go to the appointment, or I don't want to go to bed tonight, or I don't want to go into a busy, overstimulated environment. So it's escaping, it's avoiding something that someone may not like. So we're going to focus on these two messages. But by the way, like I mentioned, there are lots of messages we could be focusing on. Okay. So I'm going to give you all an opportunity to play detective with a couple of scenarios. I want you to tell me what you think this child's behavior is trying to communicate. So the first one is, you're out to dinner with your family, and your son, Johnny, is playing on his iPad. Crack for kids. He's playing on his iPad while you wait for your food to arrive. Unfortunately, the battery on the iPad wears down, and the iPad stops working. Johnny screams loudly, and he bites the back of his hand. You tend to Johnny by giving him your iPhone to calm him down, to play on, and he immediately calms down. What kind of message is Johnny sending when he did that?
He has no patience.
He doesn't have patience. We're going to actually talk about patience, but what is he saying?
That it's okay to scream to get what he wants.
That might be what the parent it might be saying. You're exactly right. What's Johnny saying? He's upset. He's saying, I wanted that. I want that. It's not working. It stopped working. He wants something, right? And he's communicating that. Obviously, the parent in this case knew he was communicating that, so they gave him the iPhone, right? Let's try another scenario.
Well, let's continue on with
Yeah.
it. Is it a good thing to, so he's had it for how long that he wore it out? Should you continue on letting him have electronics? Or should you try to say, all right, it's time to take a break?
That's a good question.
Time to eat.
That's a good question. Now, these scenarios aren't necessarily what I would suggest you do. They're just common scenarios. But in that case, you might be right. If Johnny has a history of wearing his iPad down every time, we need to work with Johnny on how to regulate his usage of that iPad. Or to let him know, hey, you got 5 minutes left. It might die here. Or we maybe need to transition him to another activity. And we've got some ways that we can do that. And actually, we're going to talk a little bit about that in just a little minute. All right, second scenario. While out to dinner, you prompt your daughter, Sally, to take a bite out of her steamed broccoli, even though you know she doesn't like steamed broccoli. Sally screams loudly, bites the back of her hand. You ask Sally to sit quietly while the rest of your family finishes their dinner, and Sally quickly calms down. What's Sally communicating there? Yeah, I don't want that. I don't want that. Now, the behavior she displayed was the exact same behavior that Johnny displayed, but 2 different messages. Communication, totally different. Does that make sense? Okay. Any questions so far? Okay. Please just yell them out. I know sometimes
Want to still try it?
we have a clinic for that. But yeah, it depends. The question is, it depends. And when I see like these scenarios, we don't know what the history is, what's gone on. So in that case, it's hard for me to say. But in some cases, yeah, I have kids who, are diabetic, need to check their blood sugar, and sometimes you just have to do things. And that's why I'm going to talk about there are cases where we do need to have kids do some of the things we want them to do. Okay. So challenging behavior is learned, it's meaningful, it's communicative, but I also want you to know that challenging behavior is manageable. And there are 3 ways that we can manage challenging behavior. The first is through prevention. Prevention is basically, these are the things that we do to decrease the likelihood of behavior is going to occur in the future, right? I didn't have to give her steamed broccoli. Maybe I gave him a fully charged iPad or never took it away in the first place. Those are prevention efforts, and those are sometimes needed. They're short-term success, but they're sometimes needed. True, challenging behavior, the goal always really should be treatment. And what treatment is, it's the things that we do either following a better behavior. Had Sally said, I don't want this broccoli, but I'll eat carrots instead, or just said, I don't want this broccoli, maybe we could have honored that, and she would have used a different behavior. Treatment's long-term, and it's what's teaching the skills to the kids that we work with to be able to not use problem behavior in the future. And I do want you to know that most often we use a combination of both. We rarely just say, just prevent it or just treat it. We want to minimize the situations that the kid finds aversive, but we also want to increase their adaptive behaviors. Okay. So prevention, like I said, may be necessary, but treatment should always be the goal. And I want to share with you some basic treatment procedures that you can do with your child, whether it's at home or if you're in the school, at school, to address challenging behavior. And earlier I mentioned those 2 messages that children's behavior tend to send. And I'm going to focus a little bit on the first message, which is, I want that and I want it now, to start off with. And then I'll get to the other message in just a little bit. I'm going to share with you a 3-step approach to addressing challenging behavior when that message is, I want that thing. I want it now.
Tablet.
Yes.
Tablet. I said I was loud and annoying when I came in here.
I work in a clinic for severe and challenging behavior. You are not loud. Okay. So step 1 in this process is we have to give the child a voice. If you have a child with disruptive behavior who does not have communication, the slides are a little bit funky. It's the problem working on a Mac. If your child doesn't have a voice, they're left to one thing, which is problem behavior. So we have to be able to give them a voice and not just teach them when to communicate, but also how to communicate. The vast majority of kids that I see in our clinics, even if they have no diagnosis, or even if they have even if they're hyperverbal and can talk your ear off, many of them don't know when and how to communicate. Instead of asking for help, they may blow up and rip something up. So we have to work on communication. This picture here is Dave Wacker. Some of you may know him. He was my mentor going through graduate school and continues to be my mentor. But he was one of the earliest researchers in this process called functional communication training. I'm going to get into that in just a little bit. And he's written a couple of books. This one's particularly good. I think it's good for both parents and providers. And it's just straight up functional communication for problem behaviors. So what is functional communication training, or FCT? How many, have any of you heard of FCT before? Okay, I'm seeing a lot of hands. Okay. Essentially what FCT is, we are taking problem behavior, understanding why it occurs, and we're going to substitute communication for that. So appropriate communication serves the same purpose or the same function or provides the same message that the problem behavior does. The research behind FCT is extremely impressive. In fact, last year we published the first randomized controlled trial of functional communication training showing that it has superior effects. There's a lot of nuance to it that we may be able to get into, but just so you know, when a kid learns that they can communicate for what they want rather than problem behavior, it's extremely effective. And it involves 3 steps. The first is we have to identify the function. So if I'm a parent of a child with disruptive behavior, first thing I have to know is, what is my child communicating? What are they telling me? What is the message behind their behavior? The second thing is we have to reinforce communication that matches that. So if Johnny engages in hand biting because he is upset his iPad battery wore down, we have to teach him to communicate that rather than engage in the hand biting. And then third, we have to be able to withhold reinforcement for challenging behavior, meaning if he bites his hand and I give him an iPhone, what I'm doing is I'm potentially just teaching him, bite your hand and I'll give you what you want. Instead, we want to teach him to communicate for that. Sounds straightforward, but it's tough. It for sure is tough. Okay. So let's go back to our model, antecedent behavior consequence, ABC. And I'm going to go through the specific procedures involved in FCT that anybody can do. Parent, provider, school teacher. I'm going to show you a visual that may make it a little more simple. So here's our ABC model. And we're going to start with baseline. And what baseline has in it is that scenario where Johnny's got his his tablet with Roblox on it. Roblox, I don't know why recently we've had a lot of kids loving Roblox, so I just put Roblox on the tablet. And for whatever reason, either we've said, Johnny, you got to put it up for now, or the battery died, or whatever. Johnny engages in some problem behavior. In this case, maybe hand-to-head hitting, maybe some crying that goes along with it. And as good parents, as good teachers, as good providers, we want to calm the kid. So what do? We usually give them what they want. Let's give it an iPhone. Let's give you another tablet. Let's give it back to you if I took it away. The problem with that, as you probably already can tell, is that it strengthens that reward circuit. So what we're going to do in treatment is we're going to do the same starter set. We're going to take away or restrict the iPad, but we're going to give Johnny a communication option. And that communication option, if this picture here shows what's called a Big Mac switch. Some kids are vocal. They can just tell you. Some kids need a picture card. Some kids need a switch. If you have a child who's nonverbal, nonvocal, an AAC evaluation is really good. Augmented alternative communication. It's a chance to get them in front of somebody who can tell you whether or not a certain device may be good for them or what the best communication forms are. But I'm going to pretend like in this case the switch was the best thing for Johnny. So we take away the tablet. Johnny hits himself, cries. He doesn't get the tablet back, okay? But if Johnny touches that switch, and in this case the Big Mac switch might have a message on it like, toys please, then immediately I'm going to give Johnny that iPad back and I'm going to praise him and he's going to have fun on it. And we're going to do that over and over again. He shows problem behavior, doesn't get what he wants. Shows appropriate adaptive behavior, he always gets what he wants. And there's ways to make this very, very efficient so that early on, Johnny immediately gets what he wants. So I might take the tablet, take Johnny's hand, touch the switch, you did it, give it to him. Okay, there's a lot of ways we can teach somebody to communicate. All right, step 2. You might be asking, do I always have to give my kid everything they ask for? And the answer is only if you want to make them happy all the time. The truth is, though, everybody has to learn to tolerate delays. I'm terrible at waiting. We're all you mentioned impatience. That's the issue here. It's like, I want it right now. So what we have to be able to do is we have to be able to teach our children to learn to wait. And we can do that. It just takes a lot of effort and energy. So the second step is teaching those delays. And the way this would look is we would use these 3 steps. So once your child is communicating reliably, not showing much behavior, we're getting them to ask for what they want. Now what we want to be able to do is go back to that same scenario, restrict or tell them, okay, we got to put it up for now, Johnny. And we're going to set up either a timer, very small set of time to start with, or an activity for them to engage in where they have to complete something, and then they can ask for it. So we set up the timer, the task, they complete that, and then they get to request it again. We're basically saying, it's not ready right now, you can't have it right now, but give it a little bit, and then you can have it. So what that would look like in a visual would be this. So remember, we take away the tablet, or we say, tablet's off limits for now. Then we set a timer. We usually start with very, very small times. In fact, in clinic, we've started with as short as 5 seconds. Just got to wait 5 seconds. But we also want to give the child some alternative activities. When you go to a waiting, or to a doctor's appointment and you're in that waiting room, most people have their phone or they've got a magazine. So the worst thing you can do is say, okay, you got to wait and you just got to sit there and do nothing, because then it's going to drive the kid mad. So let's give them something to do. Once that timer goes off, they communicate and you can have it back. Or we give them a task to do. Here are the things that we want you to do. Once you're done with these, if you ask for this, you get it back. Now, how do we move on from 30 seconds to 10 minutes or 15 minutes or even longer? We do it slowly through something called fading. Fading is slow, systematic increases. So if I have my kid waiting for 30 seconds right now, the next trial cannot be 5 minutes. We're going to start with 30 seconds. Make sure they're tolerating that. Now we go to 1 minute maybe. And in some cases, we can go further and further and further really fast. But you also have to ask yourself, what's developmentally appropriate? I've had kids who are 3 or 4 years old and they're saying, my child doesn't wait for 20 minutes or something. And I know adults who don't wait 2 minutes for something. So we have to think about the developmental level. Same thing with the task though. Make it a little bit more, either more items within that task or more tasks for them to complete. The goal is, just like you are in the waiting room, to give them something to do until they can have what they want. And the longer and longer you build that up, the more tolerance they'll have for those delays. Now, what about when they just can't have it? Yes, you go to McDonald's and you ask for the taco. It's not going to happen, right? With kids, there are going to be those times where they communicate for what they want, but they just can't have it. So they've learned to wait for what they want. Now we have to be able to teach them that sometimes you just can't have what you want. This is the tough part. But it's doable through lots of practice. We do this a lot in our clinics. Learning to tolerate restriction comes down to just a few difficult steps, but it's a process. So just as we started with the delay tolerance, we would restrict an item, but we're going to offer up, and we're going to let them know it's off limits. So if I say, hey, we're going to put the iPad away for a little bit, maybe later you can have it, that's different than if I say, we're going to put the iPad away for tonight. It's done. So we need to be honest with the kids. You have to, what you tell them has to be true. So you do want to tell them, it's off limits now. It's done. You won't have it tonight. Then you want to offer up another activity or item. If you were doing your favorite activity and somebody said you have to stop that to do nothing, that's pretty aversive. That's pretty negative. Nobody likes that. So what we want to be able to do is give them something else to entertain them, to engage with. It doesn't even necessarily have to be the most preferred thing in the world. Like, we don't want to go from an iPad off limits to an iPhone. I mean, that's the same thing. We want them to tolerate not having that same type of reinforcement.
Can I ask a quick question?
Absolutely.
I work in a school setting a lot, and is it okay to do the kind of countdown, in 5 minutes? You have 5 minutes left, and because a lot of them do.
It's not only good. I would advise you to do that,
okay.
Unless we do have some kids.
Some that do react.
We have some kids. Exactly. I always want to give forewarning to any kind of restriction or any kind of demand I'm going to present. Hey, buddy, 5 more minutes, and then we take it away, because it allows them to get used to it. It's kind of like, and by the way, I know I didn't plan for this, but think about the difference between a soft break and a hard break. Kids in the middle of a video and they have 5 seconds left, timer goes off, we don't just take it away. Let's end it. You're watching your favorite sporting event, wait till the commercial, you know? My point is, that's a soft break. Hard breaks are unfortunately a form of trying to control, and I'm okay with sometimes there's a hard break. I had a kid who was playing a video game, and I said, you get one more turn. That turn took 25 minutes. He did not die for 25 minutes on his video game. That's my fault, okay? But if I said, hey, the school bus is here, you can play until the school bus gets here, I've got to be able to cut it off because the school bus is here.
We've said that too, like at our school set, I mean, because there's times where we have to practice a fire drill. And
Exactly.
if we're in the middle of a thing, we're like, that's not an option.
Yes.
You get to come back to it.
Absolutely.
But
And I think when we have those exceptions, I always say this, if you have a child who really struggles to give up something, have some other items, activities, things that you hold back that you can give them when those occur. So if it's a totally unexpected change, oh, you know what, the iPad has to go away, but you know what, I've got this thing that you really like instead. It's a way to, yeah. But that's a really good question. And like I said, I think pay really close attention to the soft versus hard breaks on these.
yeah, we agree too, like when they're playing a game, we usually say that, or well, once you die on the game, or if they're watching a kid's YouTube video, once this video is over, even if the timer went off.
Yes.
Once this video's over, because you're like, we don't.
Yeah, we
end our Netflix.
totally agree. We watch really closely to what our kids, at least in our clinic, are playing to know, okay, this is a movie and they're 5 minutes in. We're going to give them a hard break, you know, hey, we got 5 minutes. But if they're Angry Birds and they've got 2 turns left, okay, you can finish those.
Yeah, we kind of know enough about what's on our iPad.
Yeah.
Whatever's going on that we can ask.
Exactly. Yep.
Thank you.
Yeah. So we restrict, we let them know it's off limits, provide another activity, but praise the tolerance. Praise isn't everything. Some kids may not care about your praise, but you really want them to feel good about the fact that they're handling it. So, oh, dude, you did awesome. I know that the iPad's up for a little bit, but you are doing so cool. And then praise requests, but remind them of the restrictions. So we've taught this kid to communicate and ask for the things they want, and now they're asking for it. We want to keep that going. So we don't want to just, I said no. It's, oh, you did a great job asking for that. Remember, it's off limits for today, but thanks for asking. We just really got to acknowledge that. And then what you want to do, you want to practice this kind of like what we did with the delay training, but don't do it, but you want to intersperse these occasionally. In other words, you don't want to restrict 5 times in a row, because what's going to happen is every time they request and they're told no, it's going to go on what we call extinction, or it's going to be punished. My point is, do this slow and systematically. You're not going to work on just restricting things all day today.
So how do you respond to it when you tell them that it's off limits for the rest of the day, and they keep asking, and then they start throwing in tantrum on top of asking, even though you're trying to explain, and you, after the 5th time,
Yeah.
that piano wire just really gets caught.
Yeah, and without knowing the history there, it's sometimes hard to make that decision. In the moment, one of the things that, whether you're a parent or a teacher, is to always follow what you said. If you said it's off limits, it's off limits, and you have to follow that. That predictability, that consistency is how kids learn, right? If sometimes I say, oh, you'll get it back if you throw a fit, not telling them that, but they do it. Sometimes they ask, they get it back. And if I just make it really confusing and messy, those challenging behaviors persist way, 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 way longer. Lots of research to just show if you don't have that consistency, you'll be dealing with those problem behaviors for a lot longer. And some kids, not because their parents or teachers or anybody made them this way, some kids are just absolutely very willfully stubborn. They just did, they are. I've got 2 kids. One is the most patient, she'll do anything for it. The other one is he's got my stubbornness. And I know I'm going to work with them very differently. But if you have a kid who's engaging in behavior because you've said it's off limits, the one thing you want to be able to do, make sure they're calm, or not calm, make sure they're safe. Offer up these other things, not after they show behavior. Always try to offer it up when you put it off limits, because if you wait until they show problem behavior, so let's say Johnny's playing with Roblox, and I say, Johnny, it's time to put this up for tonight. And then he starts showing problem behavior, and I say, oh, but we can go eat ice cream. Now what's happening? Johnny says, oh, problem behavior, ice cream. I'm not saying that he consciously is connecting that all the time, but it will get connected over time. The problem behavior has a rewarding outcome. So what we want to do is make sure the problem behavior doesn't have a rewarding outcome. If they don't have what they want, what they like, and we've restricted this iPad, wait until he or she's calm. Once they're calm, oh, do you want to play something else? I mean, we could play a board game, we could go watch a TV show, whatever it is. and give them those options. But we absolutely have to make sure that that problem behavior does not result in that thing that they initially showed problem behavior for. And it's not easy. In my clinic, we've had kids go for hours and hours and hours. And it's not fun, but the first time it's hours. The second time it's an hour. The third time it's 20 minutes. And it gets better and better and better. That initial pushback, we call that an extinction burst, you almost are going to expect to see that every time. When the behavior, especially the problem behavior, no longer works, it will actually increase initially. It's like slot machine, right? You won money on the slot machine. The next time you didn't win, you're going to try it again, you're going to try it again, you're going to try it again. Exactly.
I'm a
Yeah.
autism therapist
Yeah.
in Wisconsin, and we always tell the parents, pick your battles.
Yeah.
You don't have to fight the kid on every single thing all day long.
Totally agree.
Pick one thing and stick to it. That's
Yes.
your battle.
Totally agree. And pick them, be very judicious, and pick them knowing, so for example, if we are out in public, I may not pick the same battle that I'm going to pick at home. If we have to stop the iPad to go to school, that's far different than if we have to stop the iPad for dinner. And we might be able to extend dinner a few minutes, unless we told them it's going to be in 5 minutes. But you're right, pick those battles, because the truth is, we all want these reinforcers. And when we withhold them or when we're told no to them, they do elicit a lot of problem behavior. Okay. And by the way, I've got a lot on these slides, so we may not get to everything, and I'm happy to stay after if people have questions or thoughts or concerns, and we want to talk about that. But that second message that I talked about earlier, which is one of, I don't want to do what you're asking me to do. And that's a really important one, because my goal as a clinician is not to make every kid perfectly compliant. My goal is to get them to do the things that they need to do. Like I said, I've had kids who are diabetic, had to check their blood sugar. I can't have you not do that. Kids who have to take certain medications, I can't have you not do that. You have to go to school, things like that. Those are the battles definitely worth picking. And sometimes there's others. But we can practice this and we can work on this to improve this for most kids. So before we address refusal behavior, we need to ask why they're refusing. And there are several reasons why a child may refuse. One is it may be a can't do. If I ask a kid to do a task that they just don't have the skills to do, they've never learned it, it's essentially too hard, too heavy, too exhausting, they're probably not going to be able to do it no matter what you do. And we see this a lot in education. I know that we have kids who get presented tasks that may be above their level. And of course, I'd rather be the bad kid than the stupid kid sometimes. And that doesn't, I'm not calling it stupid. What I'm saying is that it really is not fun to not have the skills. That is a can't do issue, right? Then there's a won't do issue. Won't do is, I can do it, I'm just not going to. I have the skills, I have the ability, it's a motivation or performance issue. And then there's a little bit of both. Sometimes tasks are above our skill level, and I'm not really motivated to do that. And if we address if we want to address refusal behavior, we have to know why they're refusing. If it's a skill issue, it's a simple thing. We have to build their skills in this area. I'm not going to expect a kid to follow through with what I asked to do if they don't have the skills to do it. I have to teach them those skills. Let's focus on the won't do. So the kids who maybe they have the skill to do the task you're asking to, but there's either a motivation or performance issue that's getting in the way. And I want you to know there's always a competition here. The competition is between how ugly is that work task you're asking me to do and how rewarding is the outcome to it. Sometimes the reward of doing what you're asked to do is just to get somebody off your back. That's my son's reward. If Dad stops nagging me, that's all I need. My daughter, I could get her to do about anything for the smallest little piece of candy. I don't know why. It's potent to her. It is. My point is, if you have a work task that's really aversive, it's going to be harder to get a kid to do it. So if it's more difficult, takes a longer time, it's really boring, of course, a child has maybe less incentive to do it. But if the reward is really potent, so for example, if I give a kid a high five, maybe that's rewarding, but I'll bet you I could get them to do that same task that they refuse to do for a high five if I say we're going to go to Disney World for it. That's a huge reward. That's almost impossible and impractical to give. But we can get anybody to do anything when needed as long as we have the right rewards and we've made the task doable. Kids are really good at calculating. We've had kids who have said, well, I did that last task for 5 minutes on the iPad. How about the next one I do, I get 10 minutes. And it's like, well, you're figuring us out. You're saying, you're trying to maximize the reward. And there's nothing wrong with that. because we don't go to work for a pay that doesn't equal what we think we're doing. All right, so as I mentioned earlier, challenging behavior is manageable through prevention strategies and through treatment strategies. When we talk prevention for this type of behavior, we're talking about things like choice making, giving a kid a choice. Okay, you can pick up all the toys and put them in the toy bin, or you can pick up all the dirty laundry and put it in the dirty laundry bin. Now, they're both work tasks, and maybe they would have refused either of them independently, but when you give the option, for some kids, choice it can be a really important dimension. In fact, we've seen this with kids in schools where we've said, kid won't do this task at all, and then we say, well, what about if you do this task or that task? And then we see them start to do it. Choice is really important. Make the task less aversive. What do I mean by that? Make it a little bit easier. Make it a little bit less, make the duration shorter. Maybe what you're doing is you're giving them something that they have some success with, and so then it's a little less aversive. Enrich the environment. When you go to the dentist nowadays, or at least in pediatric dentistry, they give kids, they play music. They sometimes give them VR sets. In the blood draw, they get to watch movies. Enrich the environment. So when I mow the lawn, I've got a podcast on. It's a little bit easier for me to tolerate mowing the lawn if I've got a podcast on. Promote communication. Probably the number one thing for kids with refusal behavior in our clinics is to teach them to ask for help. And it's not because they don't always have the skills, some do not, but asking for help can make that task way less aversive. And that's something that most of us as adults aren't good at either. I'm one of those poorly trained tech people who I don't ask for our IT support, and it gets me into 2 hours worth of messing with my computer instead of just making a call. And then this important aspect of building up their tolerance to bigger and larger tasks, which is called fading. So for the kid who won't do an entire page of math problems, maybe we start with 1 and we give them success. We build that momentum. The next time around, maybe it's 2, and we build it up and up and up. It's like training. And then as far as treatment, it really comes down to 2 things, and these are just basic behavior principles. This isn't our intention well, let me just talk about them. So extinction is making sure that they don't get what they want for the behavior. So in this case, they don't get out of the work task. If I said you gotta pick up your toys, I have to be able to follow through with that. If I let them out of that, a child out of that, they are getting what they want. So extinction is not letting a child out of that. That doesn't mean in all cases that you hold the task on forever. We've had, our record in our clinic to do 1 little task was 9 hours, and we decided that's not the route to go with her. And then the other is way more important, which is reinforcement. Reinforcement of what? Doing the task, asking for help, the adaptive behaviors. With reinforcement, be aware that there's all kinds of dimensions of reinforcement. And there's all kinds of important rules that go along with that. For example, the immediacy of the reward. We know from research that if a child does something, the consequence following that behavior should be within 30 seconds for it to have its maximal value. Okay? So if a child does an appropriate behavior and I provide a reward 3 hours later, it doesn't mean it can't be rewarding, but it's not going to have anywhere near its maximal value, about 30 seconds. And by the way, that's the same with punishment. If a kid, I'll just pretend like I know a kid who does this, takes some food out of the cabinet at night and we find the wrappers in his room the next day, the likelihood of me having some consequence that's going to have as much an effect on that is very low. You've got to be able to provide either the consequence or withhold the consequence immediately. All right.
So you could probably just scold them then and there for having the wrappers trash not put in the trash can.
You could. You can make it a different issue. That's a good point. And we do have strategies to bridge that. So let's say a kid does something great today, and 2 weeks later we find out about it. We do have ways to bridge the reinforcer to that. It's just really hard. Or the consequence, right? So compliance takes a lot of practice, and it may seem like a straightforward process, but it's really hard. I totally get that. And I'm going to go through just a few steps on how to work on this if you were, say, at home, or even in the school, because we do this a lot in the schools too. Steps to work on compliance. The first is we have to start with something the child finds valuable or enriching. So what we always tell the parents when we're working on this is we say start with a preferred activity, high quality play with the child, give them a taste of something they want. If you want your child to, say, earn access to, well, I love cheesecake. If you want your child to earn access to cheesecake, give them a taste of it first, and they're much more likely to work for that cheesecake than if you just have it sitting over there and say, once you're done, you get to do this. So give them a taste of it. high quality attention. Set a timer during that first period of play and say, hey, when the timer goes off, we're going to do a little bit of work. I may have you pick up your toys or whatever the task is that you're going to have them do, and then let them know, but when you get done with that, we get to go right back to playing again. Remember, we're giving them a bite of that cheesecake and saying, oh, we got to take a break from that so you can come back. The timer goes off. Give them a directive in very clear, concise terms. Begin with a small directive. We're not going to ask the kid to go pick up your toys, then put the dirty laundry away, then throw away the trash. No, let's start with something small and remain neutral. If the child's doing well, praise, 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 praise. Heavy praise. If the child's not doing what they're asked to do, it's okay to still give some attention, but try to make it more neutral. I don't want the kid making it a game, but I want to be able to say, remember, you have to go pick that up for us to be able to go back to playing again. Once the task is completed, provide the reinforcer immediately. Don't say, okay, well, we'll do it later. Nope, nope, right away. Return to step one. Do it over and over again. This is not what I'm asking you to do for every task that you ask your kid to do during the day. This is what I'm asking you to do to train and practice compliance with your kids. All right, any questions at this point? Yes?
So what happens, so this is going to come from a school context.
Yes.
That represents students when schools maybe not doing what they're supposed to do that long.
Yes.
So a lot of times I see that cycle interrupted, and I get this. Staff, teachers frustrated, so call up parent, come get your kid. So we interrupt that cycle, so then we have that problem. And then of course, from my perspective, we start having legal problems.
Yeah.
And so then we have lots of problems going on.
Yeah.
How do you, what would you say?
Yeah, so as a parent, I would say if my child has harmed themselves, been harmed, I would want to know. I'm happy to come to school. But if my child is refusing, my child's destroying a table or a room with tables and chairs and stuff, I don't want the parent to come and pull them out of that context and essentially, in some cases, kind of save the day. And I know it's a lot of pressure on a parent because a parent gets told, your child's really disruptive, you need to come get them. Most of the time when we see kids in clinic who are getting picked up from school regularly, we say we need to cut that out. If the kid's safe, we don't want you coming and picking them up every day. It's exactly what you're saying. Not every kid loves to go spend time with their parents. Not every kid wants to go home. But in the context, if a kid's willing to destroy a room, they're much more likely to want to go home than they are to stay there and work. And so we just can't do that. However, if that's happening a lot, we need to rethink why is it that child's showing that behavior in the first place? What is it that's evoking that kind of response? Because we can't keep having that over and over again. Because not only do you continue to strengthen that cycle, you haven't learned anything to kind of prevent or decrease the likelihood of that. So I think we have to take a step back and say, we can't have you picking up your kid every day, but let's talk to the school and see where we can set up some strategies to make it more likely the kid does well. Does that make sense?
Yeah, absolutely. Thank you.
Yeah.
Should have known you like 5 years ago.
All right. And I know I'm getting low on time and I've got a lot to go, so I'm going to try to hit what you guys are maybe most interested in. So just so you know, I'm giving you these different types of management strategies, these procedures that we sometimes recommend in our clinics, but I also want you to know that that doesn't mean you're going to be successful. It doesn't mean the school is going to be successful. Sometimes behaviors have different messages, and sometimes these kind of treatments are not possible. If a kid is very aggressive or self-injurious to the point where they could hurt themselves or you, I'm not going to ask you just to let them beat up on you and withhold reinforcement. We've got other ways to work on that. When things don't work, it's okay to seek out help. And I want to open up, or I want to talk about just a few different options, knowing that there are lots of options in the States. I'm not saying they're all perfect and they're all great. I'm going to start with the place that I work. So I work at the University of Iowa, where we see hundreds of kids each year with severe and challenging behavior. We have quite a few clinics that are focused specifically on severe and challenging behavior, and these clinics cut across different departments. A lot of people call in and say, what do I do? I don't know where to go, and I know we have a very weird system at the hospital where in some cases it's siloed. Like if you call the right person at the right time, they'd say this clinic, and you call a different person, they say this clinic. So I'm just kind of give you an overview, but know that there is sometimes a little bit of messiness with triaging the families to the right clinics. So for those families who really just need to know a little more about what's going on with their kid. Meaning, he or she's engaged in these behaviors. I'm just not sure what's happening. We have these brief outpatient clinics. The point of the brief outpatient clinics is not to provide intensive intervention. It's to to assess the child's behavior, get what their message is telling us, and then develop some recommendations, develop some strategies, and say, let's go try these. And if they're not successful, we've got next steps. But these clinics are usually staffed by a behavioral psychologist. I've got 2 clinics where we focus on the combination of behavior and communication. So I have a speech and language pathologist who joins me for those. They do cut across different departments because in some departments we see younger kids, some departments we see older kids, and then we also do have an adult clinic as well that would see adults even outside of the school age range. The next set of clinics are our treatment clinics. These are the clinics where we think we know what's going on with the child in general in terms of the messages that their behavior is sending, and we need to develop treatments. We still do comprehensive assessments in these, and the most intensive treatment we have is our Bbs Day Treatment. It's a Behavioral Service Day Treatment, which I direct. It's only 2 weeks. So somebody might say, well, 2 weeks is not enough. I totally agree. But we've got wait lists, sometimes years, and we give the best we can. So what we're doing in that 2 weeks is we are doing an intensive assessment, really comprehensive assessment, but then we're developing a treatment, and then we're going to practice it over and over and over again. And we are not, the clinicians, are not the ones who need to learn the strategies. We develop the strategies and the treatments, and then we train the parents, the school team, the group home, whoever it is, to do those, because the only way for success is for it to continue beyond our clinic, because 2 weeks, once again, just not enough. For kids who have a lot of disruptive behavior around food, we have a feeding disorders clinic. And then we have a couple of clinics that are not exactly the same stuff I do, but they're really helpful when it comes to problem behavior. Parent-child interaction therapy, which I'm going to mention again in just a minute. Project Impact, which is teaching parents social communication strategies. Remember I said communication is key, and that's a really important treatment for that. And then we do have inpatient programs. Our inpatient programs are not necessarily going to deliver intensive behavioral therapy, but what they can be helpful for is regulating, assessing medications, because most of our kids are on some type of medication. And then also, we have a learning and ADHD clinic. Why would I mention that? Because the kids with can't do. We don't always know. We had a kid who was getting, I think he was 9th grade, and he was being delivered 9th grade work. Well, he's 9th grade. He should be getting 9th grade work. We did an assessment. He had intellectual disability, and I can't tell you how different his behavior was when we started getting him tasks that were at his level. We had to get that assessment to be able to show that, though. And then we also have medicine. Medicine is not the answer for every kid. I'm neither pro nor against medication. I've seen tremendous benefits for some kids. I've actually seen some kids have more behavior on certain medications because side effects and whatnot. But we have 2 clinics that focus on that. One is for kids more on the disability side with severe and challenging behavior. And then one, yes, some kids with disabilities, but also those with more on the mental health side, which is in our child and adolescent psychiatry clinic. We have some other good resources in the state. It's not just the University of Iowa. And I do want to acknowledge that. So one of the things, if you have a child with an autism diagnosis, ABA therapy a lot of times is helpful. A lot of times our ABA therapy providers focus a lot on the skill acquisition side, which can be really good for the communication, for example. So we will sometimes focus on the severe and challenging behavior in our clinic while the child is getting ABA therapy to focus on the communication, then we try to blend that. There's challenges with that. Some providers don't offer those services for a wide range of ages. So we see some that maybe will only go up to 9, a few that only go up to, say, 12 or 13. And you have to have that autism diagnosis. So that's not an option for everybody. And they're not everywhere. By the way, none of these resources are everywhere. I mentioned Pcit earlier. Pcit, this map here I wanted to show you, is there are providers throughout the state with Pcit. Pcit is a therapy, a really great evidence-based therapy, where the therapist is teaching the parent and the child how to interact, mostly through guiding the parent to do all of the work. Meaning that it's parent-mediated. So the therapist is telling the parent, do this, do that, try this, try this. And it's really effective. It's really great. There's a couple caveats. One, mostly targeting younger kids, so between 2 and 7 is where the primary age range is, although some will go up to, say, age 12. And then I will say one caveat is that for kids who have a lot of escape-motivated behavior, this may not be the one. So kids have a lot of refusal, and the only reason why, it's very timeout heavy. And just as sending a child home if they have disruptive behavior at school might be kind of like a timeout from school, it might actually be reinforcing for the kid. So if a kid's in the middle of a work task and we say, time out, well, that might actually strengthen their behavior. So be aware of that. Medicine, Blank Children's, psychiatry, and probably, I don't want to knock we have great developmental behavioral pediatricians at Iowa, but Nate Noble is fantastic. He actually trained in my clinics. He calls me up every once in a while, and he's the most enthusiastic guy. And O'Brien, what's going on? How do I do this? And he's just so invested in his patients. And the behavioral health intervention services. This is not the panacea. Behavioral health intervention services, or BHIS, there's a lot of agencies throughout the state who can come in and work with your child. The one caveat is, the training isn't always perfect. What we try to do is we try to bring a kid in, develop a treatment plan, and then say, let's have the BHIS providers help you implement this. Let's not just put it on them to do what they do. Let's develop this and work with you on that.
What's been your opinion on the success rate of BHIS providers being able to implement the plan with fidelity, depending on their training?
Yes, well, it's from 0 to 100, yeah. It is. It's so variable. It's not just the agency, it's the person, and there's this revolving door. We have some who say, we tried BHIS, but we had 5 different providers within 1 year, and we just didn't want to do that. That's the issue with the system. I would love to see a better system in Iowa where the BHIS was trained to deliver kind of evidence-based approaches with the family, helping the family out, not just the provider and the kid, building them in. And that's one thing I would say about ABA too. If you have a child who's in ABA, I really want to see the providers engaging the parents because they're the ones who are going to implement that. It's kind of like school teaching reading and then saying, don't do any reading at home. That's not a good idea. I'm going to skip this part and then get to questions right after this because I did, I was light on school even though I had quite a bit I wanted to say about school. But for those parents and school folks, I know challenging behavior at school can be really frustrating. And part of that is you're not there. I have more families who say, I would rather my kid be aggressive, disruptive at home than school any day. And I totally get that. But there are things you can do as a parent. First, I would say in a case where your child is showing disruptive behavior at school and they are not having much success, call in the troops, call in the support. Who is that? That's the AEA. Could be the challenging behavior teams, the autism support person or autism specialist. If the school is unwilling to have them in, that's very unfortunate. There are ways to leverage that. We need to talk about data. Okay, 3 paths of behavior. It can get better, it can get worse, or it can stay the same. And if it's staying the same or getting worse, you're not doing something. And that's not to just blame the school, but that means we need to get some help. What's that?
But you can get a teacher and a principal fired.
Yeah, I will say, when you go up the ladder, if you get to a principal level, it sometimes affects change a little bit easier.
Worked with our kid preschool through 2nd grade. Then she had to change to a different school. And needless to say, those teachers that last seen her got moved to that same school, but in that lower grade, 1st and 2nd grade, they're still in the same school. They were told by school board for her current teacher to get with them to talk over how to deal with the child. Well, never happened. We got with the principal, and it was a written mandate now. Never happened. I lost out of work, 2 weeks of work, because I ended up having to go to school every day because the same thing is basically the teacher's aide would back away from the teacher, back away from the kid, the moment the kid started showing frustration. Instead of stopping what she was doing and redirecting her, she'd back away and let the kid get violent. Well, all they had to do was talk to those other 2 teachers, next grade down, and it would have been solved.
Yeah, that communication is key. And I just saw Alicia walk out of here. Ask Resource has been huge for some of our families. We've called them in. Like, Alicia's been great. I wish she was in here. She just left, and now I'm saying all these great things. She's been in a few meetings with us, and I've been like, oh my gosh, I'm just going to mute myself and listen to her because she's great. Like I said, rally the troops. Some schools are doing great work and they're working hard and things aren't getting better, but those great schools are the ones that are willing to take the outside support. They're the ones willing to listen. And I think as a parent, these are a couple more points I was going to mention. One thing is talk to the school about what you found successful. If you found some things that are successful at home, at the very least, the school should be able to listen to that. This is what we do to get Johnny to do some things. Also, the school needs to know what your child's reinforcers are. We had a kid the other day who loved to bake food, and that could have been a huge reinforcer. We had to find a kitchen in the school and tell them, let's carve out time to do that. Most of the time, that's not always feasible in a school, but if you can find those reinforcers, it's really huge. The other thing, and this goes back to kind of even the kid coming home, don't ever be expected to consecrate the child's behavior at home. What happens in the school has to be rewarded or consecrated in the school. What happens at home, same thing. If your job when the child comes home is to provide some kind of quote-unquote punishment, that's too delayed and it's not going to be effective and it makes you the bad guy. So when schools and home work together, I totally love that. I think it's great. But don't make the consequences a home-based thing. All right, I think I'm going to stop there. Alicia, you just stepped out and I was just singing your praises about when we have these situations at schools where we need to rally the troops. It is so good. Ask Resource has been a huge one. Sometimes I mentioned showing the data. Sometimes just having enough support to come to those meetings. Because if you have enough people saying there's something going on here, something we need to change, that can be really effective. All right, I know I hogged it all of the time. What kind of questions do you guys have? Yes?
I do have a question for you. So this is more selfishly to ask.
Oh.
Yeah. Thank you. So when you you showed all the different clinic options. So selfishly at Ask, when I'm talking with a family and I know that it's at the point where they maybe need to seek out the, try to get on the wait list for the day treatment or whatever it might be, is there a good way to go about that? Because I even tried to navigate that for a family recently, and it's, gosh, I mean, it's kind of that main line, but then
Yeah.
to the point of, I'm like, no, I want Dr. O'Brien's clinic.
Yeah.
How do I get there?
And honestly, that's what I would recommend you do, because we have purposely not advertised or put out any
Sure.
press on our clinic because we get booked up so much, and I think we've been inundated at times when something's gotten out and we have all these referrals. But if you think a kid could benefit from our clinic, now especially if they're willing to be more of a cancellation case, because sometimes we're booked out a long ways, and we've had families who we saw in clinic and literally 2 weeks later we were able to get them in our day treatment clinic, which is amazing. But if you reach out to me specifically, I will find a way to make it happen. We almost always start with an outpatient visit because we want to make sure that they're a good candidate for that intensive approach, but we can also get them started on other therapies or with other providers. And I ultimately think if they're a good candidate for our day treatment clinic, we will work hard to get them in if, once again, if they're willing to come in like on a cancellation slot, that can work out.
Okay.
But yeah, I would say reach out to me because there isn't a direct way.
Okay.
And part of that is because of just the mass.
Yeah. No, I
Yeah.
assume.
Yeah.
I will recommend him highly for you. I had his predecessor start with Minden.
Thank you so much. Dave? Dave Wacker? Yeah.
Caitlin Pollock, I don't know if you remember her.
I do. I have good at,
Quite a few of them in there.
yes.
And then
Thank you very much. I think that was,
Well, I was going to add one other thing. So Matt mentioned, that's a time, especially with the day treatment clinic, like bring in, it's a time to train family members, it's a time to train school staff. Really advocate for that with your school staff as early ahead of time as possible, because I've been on the other end where I'm a former teacher, I've had students go through the clinic. It makes such a difference if you can get staff that are working directly with them.
Thank you. That was one of the points that I didn't get to say, and real quick, I'm going to say it. If there are behaviors at school and we want that addressed in our clinics, pull in the school, bring them to the clinic, bring them to the day treatment clinic, send paperwork that they have. It's very hard for us to work with behaviors that are occurring at school when we're not in the school, so the more information, especially if you can bring the school staff, that would be great. We've had at times, in one case we had a superintendent, a principal, 2 teachers, a para, and a speech and language pathologist all join us for 2 weeks. That's a lot. But that was a school that was really wanting our support.
well, thank you very much. Everything was
Yeah.
wonderful.
All right,
And that
thanks.
was a perfect example of exactly how we can work together to have some questions answered. So do you have any other handouts that you would like to
So
have available?
I did want to say, so I know that I talked about the clinics. There's so many other resources. Compass. This is another resource that I didn't get a chance to really mention, as well as CDD. If you want one of these, I'll just leave them on the table. Please grab those. As I mentioned to Alicia, reach out to me if a child really needs day treatment. We can find a way.
Sure, perfect. Okay, and then one more reminder, if you guys could please do those evaluations. If you just want to fill them out and leave my table, I will collect them for you. Again, this is going to be your session number 1. If you could just give us that feedback, we would greatly appreciate it. And is there any last things that you need from us, or?
No, that's
Okay.
it. Hey,
Thank
Ed.
you very much.
Good to see ya. What time do you guys present? Turn this. Oh, okay. I'll see if I'm back by then. I gotta go to lunch. Ah. I saw Patty already. That's all. Actually, she's the only one I've seen. Mike's roaming around here somewhere.
She's up to date.
Oh, is he?
In the another section.
He's in the session. Okay. I may stop and say hi, and then see if I can get back to see you guys present.
Yeah.
It's good to see you. It's always funny. Run into you here, and 2 hours away from home.
Good.
Real quick. Great presentation. We're actually, we live in Northwood, so.
Oh, yeah.
So we're close. We'll have to definitely think about the whole cancellation thing and stuff like that.
Yeah.
But, surprisingly enough, Iowa City School District is not the greatest about doing stuff like this.
So
So a little
I
surprising.
just moved into Iowa City Schools this year because we actually lived in the Quonset. I commuted for years. And yes, you're right.